Strategies behind the sling, swing, the brace matrices for the upper extremity: elbow, shoulder, wrist, scapulothoracic pathologies, anywhere from ORIFs down in the wrist, and other fracture pathologies down in the hand and the wrist. Elbow, our UCL reconstruction, so our ulnar collateral ligament via our Tommy John surgery, flexor common mass repairs, various forms of our medial anterolateral epicondylitis, from some of our overhead swinging, throwing athletes, which would medial epicondylitis fall into the category of our flexor common mass. All the nerve-related pathologies with regards to the shoulder. And these are all strategies that we'll use weekly. So our reverse and total shoulder arthroplasties, replacements, our slap tears repairs, rotator cuff repairs, in combination with our subacromial decompressions, clavicular and scapula fractures, which are super gnarly, some of our pneumothorax related type stuff, and a combination of some of our co-contaminants that ultimately could be some manipulation under anesthesia via some adhesive capsulitis, some glenohumeral joint capsule related pathologies and hypomobilities, in combination with our impingement syndromes, which result through our subacromial decompressions and our bicipital pathologies. But ultimately, we use these body and arm strategies for a few different reasons. We want to restore the function of the individual, get them back to where they were, create healing so that they're happy. So taking this all into effect, a lot of this depends on the individual and their situation. What do we mean by that? Okay, well, we need to look at the individual as the individual and not as a protocol. We don't dish everybody out the same exact thing based on several different reasons. This individual, in terms of their age, comorbidities, previous medical history, has accumulated a lot of different things that's going to specifically affect the healing process. Okay, what do we mean by that? Well, what we mean by that, looking at this individual, was there a mechanism of injury? Because if there was, we need to start looking at the root of the pathology and the problem. And even if there was not, we need to use the rest of the body as a way to facilitate motion indirectly to the shoulder, because we have precautions and contraindications for different things that we need to avoid to allow proper healing. And whether it's pre-surgery, post-surgery, or avoiding surgery, some of our PRP related type functional medicine based approaches that are used for a lot of this stuff, the acuteness or chronicity of the condition will ultimately lead us to use certain strategies in certain cases at certain points of times throughout this progression of getting this individual back on their feet. So eliminating the root of the problem is important, because otherwise the condition in which they had surgery for, or that we're rehabbing from and trying to avoid surgery, is ultimately just going to come right on back. So we need to know the body as a whole. And we also want to be able to use motion and indirect motion as a way, especially initially, as that first 6 to 8 weeks is the most sensitive time frame of healing. It doesn't mean by any means that everything is done healing at that point in time. It just means that healing is very sensitive that first 6 to 8 weeks. So what do we mean by healing? Well, healing means that we can, based on these conditions, use motion as a way to facilitate healing, the release and reproduction of collagen, densest form of protein in the body, to help repair and replace tissue throughout the body. And these cells are always and constantly turning over anyway. So within the body, osteoblasts are cells and bones that create new bone. We have, in terms of our tendinous, ligamentous, and fascia-related cells, fibroblasts. Those create those form of cells specific to those tissue. And then we have chondrocytes. Chondrocytes are cells that produce more cartilage. And so we've got a wide variety of things to factor in and include with regards to this process. So ultimately our strategy, we've got precautions to avoid or to bypass. Again, based on the condition, post-surgical intervention, there's going to be some weight-bearing precautions, There's going to be some active range of motion precautions. There's going to be certain positions that maybe an arm is positioned in a brace or a sling, elbow-wise, so our UCL reconstruction and our flexor common mass repairs. Shoulders, certainly for our slap lesions and tears, rotator cuff repairs and debridements, subacromial decompressions, and then also when we're digging into fracture-related type stuff, the physician wants to protect that individual and oftentimes advocates a progression of passive range of motion, active assisted, and active range of motion, so that we're through these precautions avoiding a position. Well, the functional approach to this is that we want to adhere to these precautions and be smart about it, but we also want to use motion to create indirect motion. Let's say if we have an elbow pathology or shoulder pathology, we want to use the legs and the arms to create indirect motion, what we call a body on arm motion. So we'll use the hips to specifically affect the lumbar, thoracic, cervical spine, thoracic spine affecting the scapulo-thoracic joint, scapulo-thoracic joint affecting the glenohumeral joint specifically affecting from the top down the ulnohumeral joint down to the wrist joint. And so three-dimensional motion-wise, we can affect all of those articulating points, and all those articulating points have a lot of tendinous and fascia-related joint capsules and other fascia that cross them, specific and needing help with that healing process. And so body on arm motion, we're able to be very proprioceptive specific by using these mechanoreceptors within our joint capsules and within all of our tissue, and using the stress strain curve as a specific way to create healing, to create essentially our body on our motion, which is very specific to what we do in function. We have body on arm related motion for a lot of what we do throughout our days. With regards to the stress strain curve, incorporating into this healing process, stress strain curve. Okay, what does that mean? Stress versus strain. Stress means we're specifically overcoming the effects of gravity, momentum, inertia, and ground reaction forces by being able to properly decelerate and stabilize motion three-dimensionally, sagittal, frontal, and transverse planes, so that we can decelerate, stabilize, and then eventually be able to produce some motion. Strain is ultimately, which a lot of times with these pathological and degenerative conditions, ultimately lead us to the point in which we weren't able to overcome the resistance of gravity, momentum, inertia, and ground reaction forces. Therefore, we had a lot of compensatory and compensation-related patterns in which we weren't able to move very efficiently. So, a typical, and based on the individual certainly, and as we can see here in terms of the spine, if we have the scapula sitting on the rib cage, we can use everything down and below it to specifically affect, let's say like the shoulder joint for instance, we can have the scapula move all day on the humerus as long as it's protected in the sling and in the brace, and as we progress through to some of our weight bearing progressions and holding onto things, while maintaining good adherence to and abiding by and being obedient to the protocols that have been set up with regards to contraindications. But we like to test the waters because we know that truth says that we should know how to heal. We need to know how to heal. We must know how to heal by using motion to do that, and that these precautions that we've been given don't make a whole lot of sense at all. So what we'll initially do, we'll see what the patient can do based on their age and functionability, how far removed from surgery they are. Coincidentally enough as well, we'll use this motion as a way to bypass having to use pain meds, hence a big issue with the opioid crisis today. So typically what we're going to do, we'll test out, we'll have someone hang on to a countertop, a railing, a post. We've got the true stretches here, and we'll start with some of our lunge pendulum swing matrix progressions while hanging on. We can use a dowel as well, and that would be a progression from hanging on. We would then progress to open space with our pendulum swings, lower extremity lunge drivers, and upper extremity driver, while that arm is basically hanging out in that brace. We'll do the same thing with our stability matrices. We'll start with anchored upper extremity position, and we'll go after creating the motion while our arm is in the upper extremities in the brace or in the sling. One of the next things that we'll move on and along to is, and we consider that our passive range of motion. Everything's done passively, even though we're getting a lot of great indirect motion. And again, the emphasis is on the motion, not an end range position, because the motion is what facilitates those cells within our body to create new tissue, to help resist deformity, to be strong, so that when we start to get weight bearing and movement wise, that tissue, the ability to decelerate three-dimensionally, eccentrically, and to stabilize is great, so that ultimately we can move a lot better. We'll progress then with an upper extremity that's in the brace or the sling, upper extremity fixated, meaning barely hanging on, railing, post, true stretch, or pretend like there's a countertop or a chair in front of me, either holding onto a chair or hand on the countertop. And so we'll initially start very conservatively, again, with just getting the motion. We're starting to make our passive range of motion, our functional passive range of motion, to an active assisted almost. In terms of upper extremity, little involvement. So it's a hybrid of a little passive and active range of motion. We'll go with our 3D lunge progressions. If that's okay, then we can start to slowly kind of sneak in the unaffected upper extremity as a driver with our nose, head, and eyes. So we'll fixate those guys. And then we'll go through our stability matrices, doing the same thing, fixated, and then using upper extremity or the nose, head, and eyes as a driver. And we'll progressively move from being a little more conservative to being a little bit more liberally conservative, if that makes sense, in terms of where we're at, again, in those stages of healing. Right upper extremity, when we get to that point in time, we'll progress to removal of the brace or the sling, to the same things that we just went through with our lunge, pivot matrices kind of hanging on. We're a little more free to maybe let the arm kind of hang with our lunges while we're holding on, and then the free space with our 3D lunges, and then our stability matrix, swing, sling matrix, progressing to, okay, now we've got a little more freedom for our active assisted / passive range of motion lunges, including upper extremity, nose, head, and eyes, 3D lunges, 3D single leg stability matrix progressions, and all of our dimensions. 2